All right, welcome everyone. Today we're doing something a little bit different, a special kind of explainer. Think of it as a masterclass. We're going to simulate a high-stakes consultant surgical exam. I'll be your examiner, and you get to be the candidate. We're diving into a classic case, one that you absolutely have to know inside and out. You ready? Let's go. The clock is ticking. All right, candidate, let's begin. You have a 43-year-old female who's been sent to you by her primary care doctor because of hypercalcemia. So, how do you approach this patient? Your first words here are crucial. They set the tone for the entire exam. What's your plan? Okay, so you've decided to start with the basics, which is exactly the right move. A solid history and a focused physical exam. This is where you start to gather all those little clues, piecing together the clinical picture. So, let's hear it. What did you find out?
All right, examiner. So my patient is a 43-year-old woman, and she's actually medically free. No other issues. The really key thing here is that this hypercalcemia was an incidental finding on a routine checkup. She's completely asymptomatic. None of the classic bones, stones, abdominal groans, and psychic moans. Her only past surgery was for a perforated ulcer, but that was 6 months ago, and it isn't related. And just as important, I asked about family history. There's no history of endocrine cancers, which is good to know.
Okay, moving on to the physical exam. Overall, she looks well. I checked for any signs of an over or underactive thyroid, and there's nothing there. Then I did a careful neck exam. It's completely unremarkable. I couldn't feel any lumps, no thyroid mass, and no swollen lymph nodes. It's really important to mention these negative findings because it shows I've looked for them.
Okay, excellent. That was a really clear, concise presentation. You've laid out the foundation perfectly. Now, the examiner is listening to all this, and the next move is predictable. They're going to test how broad your thinking is. They need to see that you're not just tunnel-visioned on one diagnosis, but that you're considering everything this could possibly be.
So, candidate, based on what you've told me so far, give me your differential diagnosis for this patient's hypercalcemia. And there it is. This is the moment to show you can build a logical framework to really demonstrate you understand what can cause high calcium.
Okay, well, my differential diagnosis is pretty broad. For an outpatient who's asymptomatic like this, the number one thing on my list has to be primary hyperparathyroidism. But I can't ignore other possibilities. Malignancy is a big one, especially in patients who are already in the hospital. I'm also thinking about granulomatous diseases, things like sarcoidosis or TB. And then you've got milk alkali syndrome, or maybe it's drug-induced from something like a thiazide diuretic or lithium. And of course, there are the rarer causes, like familial hypercalcemia, hypocalciuria, Paget's disease, or even just prolonged immobilization. I want to keep all of those in mind for now.
That is a fantastic, comprehensive list. You've shown the examiner you have a really solid knowledge base. So, what's next? Well, you've got this huge list of possibilities. Now it's time to use some targeted tests to start crossing things off and zero in on the real culprit. Let's take a look at what the investigation showed.
Well, the investigation results really cleared things up. We've got high calcium in both the blood and the urine. But here's the clincher. The parathyroid hormone, the PTH, is also high. Now, having a high PTH at the same time as a high calcium, that's the biochemical signature of primary hyperparathyroidism. So to find the problem gland, we did an ultrasound, which pointed towards a possible adenoma on the left inferior parathyroid. And then we confirmed that with a sestamibi scan, which lit up right in that same spot. It's a nuclear medicine test that's great for showing overactive parathyroid tissue.
So with all that evidence piling up, there's really only one conclusion you can draw. It's time to state your diagnosis with confidence. Examiner, based on the biochemistry, that inappropriately high PTH with the high calcium, and the localization studies that pinpoint a single adenoma, my definitive diagnosis is primary hyperparathyroidism.
Correct. Excellent work navigating the diagnosis. But getting the diagnosis is only half the battle, isn't it? Now you have to formulate a management plan. This patient needs surgery. So, talk me through it. How are you going to prepare her for the operating room? My plan starts with the patient herself. First, I'd sit down with her and explain the diagnosis and why we need to do surgery. It's absolutely essential to do a pre-op vocal cord check to get a baseline for her nerve function. The surgical plan itself is a focused exploration of the left side of her neck to remove that adenoma, using the scans as our guide. I'll get her admitted, make sure she's in PO and has IV fluids running, and order prophylaxis for DVT and stress ulcers. And of course, the final, crucial step is getting informed consent, making sure she understands all the risks and benefits. Okay, that is a textbook pre-op plan. Patient-centered, safe, perfect. So let's fast forward. We're now in the operating room. You have the scans, and they give you a roadmap, but surgery is never that simple. It's dynamic.
A great surgeon has to think on their feet and, most importantly, know their anatomy cold. Tell me, candidate, when you're in there, how are you going to tell the difference between a parathyroid gland, a thyroid nodule, and just the lymph node? Examiner, it really comes down to the visual appearance. A parathyroid gland has this classic golden brown color. It's usually nestled in some fat, and when you cut into that fat, the gland just kind of pops out. A thyroid nodule, on the other hand, is usually a lot more vascular, it's firmer, and it's a darker reddish-brown color. And a lymph node? That's going to look more light beige or even whitish, and it has a kind of glassy texture to it. Okay, now comes the stress test. The examiner is going to throw you a curveball, something that happens all the time in the OR. All right, you've explored the area where the scan said the left inferior parathyroid should be, and it's not there. What do you do now? This is where you can't panic. You need to show you have a systematic plan. Okay, if the gland isn't where I expect it, I'm not going to just search randomly. I'll start a systematic search. The first place I'll look is by mobilizing the thyrothymic ligament and checking inside the thymus gland because that's a really common place for it to hide. If it's not there, my next move is to open the carotid sheath and search all the way from the bifurcation down to the base of the neck. And if it's still missing, I have to consider that it might actually be inside the thyroid gland itself. At that point, I'd use an intraoperative ultrasound to look for it, or as a last resort, I might have to do a thyroid lobectomy on that side. Okay, so let's say your systematic search paid off. You found the adenoma hiding in the thyrothymic ligament, and you removed it. Now, you've sent off a blood sample for a rapid intraoperative PTH level. The lab calls back. Your PTH level has dropped by a whopping 60% from the baseline you took when you started the case. So, what does that number mean? Well, this is absolutely crucial. A drop of more than 50%. That's what's known as the Miami criterion. It's the biochemical proof that you got the right one. You've removed the source of the problem. This is the data that tells you you can finish the surgery. With a 60% drop in the intra-op PTH, I would confirm hemostasis, close up, and terminate the procedure. I can be confident it was a success. That's exactly right. Excellent judgment in the OR. So the surgery is done, but a surgeon's work is never really over, right? Now comes the post-op period, and this is just as critical. You have to be on the lookout for potential problems and manage the patient's recovery very carefully. Post-operatively, there are a few key complications I'm going to be watching for. The most urgent one is a neck hematoma, bleeding that could compress her airway. That's an emergency. I'll also be watching for any sign of recurrent laryngeal nerve injury, which would show up as hoarseness. And then there's the paradox. After we've just treated high calcium, we now have to worry about low calcium, or hypocalcemia. This can happen because of something called hungry bone syndrome. Basically, the bones have been starved of calcium for so long that as soon as the overactive gland is gone, they just start sucking up all the calcium they can find from the blood. And that brings us to our final and kind of a mind-bending question. Let's say your patient starts to complain of tingling in her fingers, and her blood work shows she's now hypocalcemic. So is that a complication, or is it actually a sign of success? It's this strange paradox, right? The very thing that's causing this new problem, the hungry bone syndrome, is also the ultimate proof that you've cured her disease. You've removed the driver of the whole process. Something to think about as we wrap up this Viva. You did a great job.